So looking at its femoral regions, for example, if that's where they inject for the subcut abscesses, and definitely examining the heart, looking for murmurs, examining the back to rule out things like discitis.
Okay, great. Yeah. And so would you say the blood culture gram stain is consistent with the clinical picture in this case?
Yeah, absolutely. So phlebitis and then IVDU and the clinical picture that you describe implies and definitely would, and that would definitely corroborate with a Staph aureus bacteremia.
Okay, and then finally, you mentioned MRSA, which I think we should consider. If this was MRSA, do you know any antibiotic that you might use instead?
So I'd use a glycopeptide like vancomycin or teicoplanin.
You identified here straight away from the start, from the blood culture result, this could be a Staph aureus bacteremia, and you've convinced me that you recognize that this is a very significant infection. Staph aureus bacteremia is one of the worst infections that we treat, or one of the most serious bacteremias we see, maybe the most serious. You've correctly told me that you need high-dose intravenous antibiotics for a prolonged duration. And you've given me IV flucloxacillin, which is going to be our #1 choice for an MSSA bacteremia. I'm convinced that you've linked the blood culture to the clinical finding. You're not surprised to see a Staph aureus in the blood culture bottle, given this patient history.
I didn't have a chance to think about time too much, to be honest with you. I was just trying to make sure I gave the main answers quickly. And I think one thing I learned from the course was front-loading your answers.
Yeah.
So I made sure to do that when answering these questions.
Yeah, no, I think that's absolutely key, because the time just absolutely flies in these interviews, and you've only got 10 minutes and 6 minutes respectively for your clinical cases. So it's a case of getting it all across.
This is the knowledge video for C. difficile infections, or CDI. So to introduce C. diff infections, essentially when you think of this topic, there are 8 main points that I would like to cover, or that I think you should understand when we talk about C. diff. So these are in this order. So background to this infection and why C. diff matters, why we hear about it quite a lot. 2, the strategies for prevention of C. diff, which of course involve the principles of good antibiotic stewardship. 3, isolation of the patient, and ideally this should be done on clinical suspicion grounds rather than waiting for testing and test results. 4, how to interpret the test results. So there's the idea of C. diff antigen or C. diff antigen and toxin being positive. So how do we correctly assess that? 5, the assessment of severity in a case of C. diff, and also monitoring for the possible complications in such a patient. 6 is treating C. diff infection specifically, so targeting the C. difficile. 7, what to do with existing antibiotics when a patient requires them still for the infection that they were first prescribed for, and strategies to tackle that. And then 8, appreciation that in C. diff, we actually see quite a lot of relapse, and the more relapses a patient has, the more frail they become. And indeed, this threatens to become an intractable infection. So strategies for avoiding that and what to do when that happens. So really, I think it's these 8 principles. 8 is a lot, but I think if you focus around these and answer and consider